Hello, and welcome to Making Sense of the Evolving Treatment Landscape in Ovarian Cancer Care, Pharmacy Perspectives on the Parp Inhibitor Therapy. I'm Thomasina Morris from the Moffitt Cancer Center in Tampa, Florida, and I'm joined by my colleagues, Dr. Carolus Hanna from the Mayo Clinic College of Medicine in Rochester, Minnesota, and Dr. Judith Smith from the UT Health McGovern Medical School in Houston, Texas. Before we move on, I'd like to thank Medical Learning Institute and PeerView for providing this session, and AstraZeneca, GlaxoSmithKline, and Merck for providing the educational grants for this webcast. If you haven't already, please complete the pre-event survey and look out for poll questions we'll be posing during the session. Ask your questions by entering them in the space provided. On the following slides are our disclosures. Please visit us at peerview.com/ovarian2022, where you can apply for credit and download the slides and practice aid. Today's agenda: introduction, status of ovarian cancer, and the landscape of PARP inhibitor therapies. Pharmacy masterclass and practicum sessions, case discussions, mini lectures on the evidence supporting PARP inhibitors in ovarian cancer and the role of pharmacists in patient care. Today, we'll just go over an ovarian cancer snapshot. As many of you know, with ovarian cancer, it's a silent disease, not detected early in a lot of young women. By the graph, you can definitely see where it's a distant metastases when patients are diagnosed. Estimated new cases in 2022 was over 19,000, where the estimated deaths in 2022 was over 12,000. Our 5-year survival at 49.1%, or almost 50%, is a good survival, but not good enough. And that's why the PARP inhibitors can play a major role in increasing this survival. The median age for our diagnosis is approximately 63. As you can see by the age group, most women fall into 55 to 64. But we have had young women in the age of 20 and older patients over the age of 84. By looking at the PARP inhibitors for ovarian cancer that are FDA approved, you can see how the FDA approval for PARP inhibitors has started in 2014 up until 2020. You can download the practice aid here, but this gives you a snapshot of how PARP inhibitors have trended from 2014 to 2020 by looking not just by BRCA mutation, but also looking at HRD as well. PARP inhibitor for FDA approvals is listed here, and this is just a good slide to go and look at when you're looking specifically for treatment indication, maintenance indication, recommended dosage, and when these PARP inhibitors were approved. So now, let's shift to our case discussions and mini lectures on evidence surrounding the use of PARP inhibitors in ovarian cancer and the roles of pharmacists in patient care. The first case for the treatment choice for a patient with ovarian cancer. We have a young woman named Helen, a 66-year-old woman who presented to the emergency room with flank pain and diaphoresis. Her CA-125 equals 722. CT resulted with bilateral ovarian masses, peritoneal caking, and retroperitoneal and periaortic adenopathy. No evidence of metastatic disease. Genetic testing was BRCA positive. Status post, she had neoadjuvant paclitaxel carboplatin for 3 cycles. Then she had a hysterectomy, oophorectomy, omecectomy, optimal tumor debulking, which resulted with pathology from stage 3A. Then she received 4 more cycles. After the first 3 cycles, her CA 125 went down to 29, then went down to 13 after both surgery and chemotherapy. The question for us is she a candidate for a PARP inhibitor therapy? As we look at the role of pharmacists and the next steps of these patients, here are pearls to consider when you're asked, how would you proceed in determining if this patient was a candidate for PARP inhibitor? You assess the impact of comorbidities, genomic testing, and/or treatment toxicities on treatment selection. Review medications and screen for drug-drug interactions, which is very important. Provide education and counseling when starting a new regimen. Recommend interventions for supportive cares and concerns for these patients, and submit appeals to insurance for denied medications. As pharmacists, we do this every day, but now we're looking at PARP inhibitors oral treatment that we can help our patients be successful with. I'd like to hand it over to Dr. Carolus Hanna, the Oncology Pharmacy Manager at M Health Fairview in Maple Grove, Minnesota, an Assistant Professor of Pharmacy at the Mayo Clinic College of Medicine. Carolus, can you take us through some background of PARP inhibitors and important considerations when thinking about a case like our patient, Helen?
So I think for us, it's very important for us as pharmacists to really understand the mechanism of action for PARP inhibitors before we delve into our clinical content, our clinical trials, and where we kind of sit in terms of this treatment landscape in terms of managing patients with ovarian cancer with a PARP inhibitor. As many of you know, there are a lot of ways where DNA damage and DNA repair there are a lot of processes involved in that process throughout, the cancer care armamentarium. Now, when we look at PARP inhibitors specifically, or these patients with gynecological malignancies such as ovarian cancer, we know that the PARP pathway does play a key role. What PARP is, it's poly-ADP ribose polymerase. It's a protein. There's 1 to 3, and oftentimes PARP1 tends to be the most prevalent. But what PARP really does, it allows the body, it's this protein that allows the body that if there's ever a time that there's a DNA break or some type of mismatch in the DNA, these PARP proteins or PARP enzymes can actually recognize that in our body and repair that DNA. In terms of that, when we allow a patient to receive a PARP inhibitor, we inhibit that repair pathway. And what we've learned over time is that that is very effective in treating patients with things like ovarian cancer, but also like breast cancer patients. That can also be an effective treatment modality. What we also do know is that these patients and many of our cancer cells versus healthy cells, they can have something called HRD. And what HRD is, it's a homologous recombination deficiency. And what the homologous recombination deficiency is, it really works outside of PARP. Oftentimes, it's when these patients may have a double strand break, and these HRD proteins, BRCA1, BRCA2, and various other mutations, when you are not deficient in HRD, the BRCA proteins and other proteins can help recognize further DNA breaks and DNA complications and try to repair those. But in our patients with HRD deficiencies, many times because they have that deficiency, they're not able to repair that DNA. Ultimately, when coupled with something like a PARP inhibitor that inhibits the PARP pathway, but also having HRD, being HRD deficient, these patients at the same time, we oftentimes see a lot more DNA damage, accumulation of that DNA damage, and ultimately apoptosis or cell death. Now, looking at HRD specifically, so when we look at our ovarian cancer patient population, we know that about 50% of these patients do have some type of HRD. So there is this deficiency in place that can potentially add to the overall effectiveness of our PARP inhibitors. We also know that a lot of these specific HRD deficiencies are associated with some type of BRCA1 or BRCA2 mutation. These do tend to be the most common mutations in our ovarian cancer patient population that are associated with HRD. About 16% of our patients, as Dr. Morris has briefly mentioned when we were talking about our FDA approvals, 16% of these patients may have a germline BRCA mutation or BRCA mutation, and anywhere from 4 to 7, 4 to 10% of these patients may have a somatic BRCA mutation. Now, so testing, that tells us really that it's important for us to know which of our patients have some type of BRCA mutation or are pretty much HRD, because then you could identify select groups of patients that could be appropriate for select therapies. So that's an important thing to understand when we are managing our patients with ovarian cancer, particularly with a PARP inhibitor. The graphic on the left just really shows you the various types of Hrd deficiencies outside of BRCA1, BRCA2, and what some of those prevalences are. And we do provide that for you as a resource. Now, how do we identify select patients who may have this HRD deficiency versus those who are HR proficient? There are testing strategies. The two of the most common ones, the My Choice and Foundation One LOH. Really, what these tests tell us is that what we know is that this HR status, whether it's deficient or proficient, is determined by the amount of genomic instability score or how much genomic instability the patient's DNA may have. Ultimately, a tumor is deemed HR deficient if their genomic instability score is 42 or greater, or they have some type of BRCA mutation, because the BRCA mutation is almost always associated with HRD. Now, in our patients who are deemed HR proficient, so they do have that ability to their body to correct those DNA, double strand breaks, etc. These patients would have a GIS score less than 42. So there's less instability. So they're deemed HR proficient. And then otherwise, that you are not able to determine HR, maybe based on sampling, etc. And that will really lead me into some of our clinical trials that have led to some of the approvals that Dr. Morris highlighted earlier. Both Dr. Smith and I will cover some of these trials. So we'll start off with one of the, in my opinion, I think it's one of the pivotal trials that has really helped establish the role of at least maintenance PARP inhibition for patients in the frontline setting with advanced ovarian cancer. So SOLO-1 trial, we now have long-term follow-up on the SOLO-1 trial, placebo-controlled trial, so it was olaparib versus placebo. We have PAOLA-1 trial, which evaluated the role of combination VEGF inhibition with something like bevacizumab plus olaparib versus just VEGF plus placebo. And then the PRIMA trial also looked at Neraparib versus placebo. When we talk about how we approach treatment and how we address certain patients, so before we get into our clinical trials, it's important for us to understand where our guidelines sit in terms of management of patients with ovarian cancer. So when we look at our ovarian cancer patient population and we look at some of the schemas from our National Comprehensive Guidelines, really for your early stage disease, so your stage 1 disease, whether it's 1A or 1B, oftentimes, these patients will undergo some type of surgery. They may undergo some type of platinum-containing therapy, but oftentimes that is really it in terms of their treatment course. They go on to observation, so they'll have some monitoring and follow-up. But once you get into stage 2, stage 3, and stage 4, these patients in the frontline setting, platinum-containing chemotherapy, platinum-based therapy still plays a critical role in the management of this patient population. Now, after patients are treated with their platinum-containing regimens or the platinum-containing chemotherapy, as you can see in the gray section on the slide, we really begin to ask ourselves, number one is, were they exposed to things like bevacizumab prior or not? We look at things in terms of their BRCA mutations. Do they have a BRCA mutation? Do they have BRCA wild type? And we also look at what type of response has the patient had thus far to their prior therapy that they received. And really the key takeaway message here is if you look on the far right-hand side of the slide, across the board, almost in every scenario, maintenance therapy or long-term therapy for some of these patients after initial platinum-containing chemotherapy does play a critical role. And it really speaks to that timeline that we've seen as early as 2014 into 2021, where we've seen numerous therapeutics move into this space. So only select groups of patients, based on the types of responses that they had, based on their BRCA mutation, may be appropriate for observation. But still, yeah, and you'll see the clinical data, majority of these patients do benefit from some type of PARP inhibition. So that takes us into the Solo 1 trial. So talking a little bit about Solo 1, left-hand side, you see the inclusion criteria in terms of the study schema. So these were newly diagnosed patients. They had a fecal stage of at least 3 or 4 and had high-grade serous or endometrial ovarian cancer. They could have had peritoneal cancer or fallopian tube carcinomas as well. Now, these patients had germline or somatic mutations in their BRCA gene and had a standard performance status of 0 or 1. These patients had to have had cytoreductive surgery, pretty standard of care, and they had to be in a clinical CR or PR after receiving platinum-based chemotherapy. What we did in this clinical trial, we compared olaparib 300 milligram BID or twice daily versus placebo. Placebo would have been your standard of care because what we would have done prior to PARP inhibitors and select maintenance therapies would have been just monitoring these patients. So placebo was certainly an appropriate control here. Randomized 2-to-1 ratio, and patients continued until progressive disease or unacceptable toxicities. If patients had no evidence of disease at 2 years, they stopped treatment. And if patients had a PR at the end of 2 years, they had the opportunity to continue therapy. The primary endpoint of the study was an investigator-assessed PFS per the RECIST criteria, and secondary endpoints was progression-free survival by blinded independent review, PFS2, overall survival, time from randomization, and the remaining criteria is listed there for you. And this trial even looked at health-related quality of life factors for patients. And this is really where I think the efficacy data from PARP inhibitor maintenance speaks volumes for this patient population. So as you can see at 2 years, so the 24 months mark on this Kaplan-Meier curve, that's really where many patients got off of therapy. But as you can see that the Kaplan-Meier curve separates in terms of progression-free survival benefit for these patients very early on, and at no point in time does the Kaplan-Meier curve intersect. The median progression-free survival, we now have data, as you guys can see, 60 months out, whereas there's that 48% versus 21% benefit to favoring the PARP inhibition. So these patients, median progression-free survival was 56 months for olaparib-treated patients versus about 14 months for placebo-treated patients. Now, the median treatment duration for olaparib was 24 months. Patients tolerated therapy for 2 years. Placebo was 14 months. That's most likely due to progression, requiring something else, getting off of study. There are practical considerations that are important for pharmacists in terms of patients who are treated with olaparib. So in terms of dosing of olaparib, it is dosed at 300 milligram PO BID, and it does come as a tablet formulation at 100 to 150 milligram to allow for dosage adjustments, whether it's based on an AE or if it's based on creatinine clearance or renal impairment. In terms of olaparib, there used to be a capsule formulation, which is no longer really an issue for us in practice. But so some considerations, for example, if you're going to put your patient or reduce them on the 250 milligram PO BID dose, one of the important considerations and counseling points for pharmacists is that these patients are going to be taking 2 different tablet strengths, the 100 and 150. So we always have to make sure our patient knows what to take and how to take it. Now, in terms of creatinine clearance, olaparib is one of the only PARP inhibitors where we actually have a dose recommendation between a certain range. So 31 to 50 mils per minute, we do have to dose reduce our patients to 200 milligram PO BID. Now, adverse events that are common with our PARP inhibitors, one of the most prevalent AEs that we do see do tend to revolve around hematologic adverse events. So a lot of times you will see issues with pancytopenia. You'll see anemias, which are pretty prevalent, neutropenia, as well as thrombocytopenia. So we may have to dose reduce for many of these hematologic adverse events based on patients. We also see nausea and vomiting as sometimes a problem. Now, other things rare, MDS and AML, but again, generally it's going to be around those hematologic AEs and some GI side effects. So it's important to note that our patients do have to get a CBC and a CMP baseline monthly. It's very important early on into their treatment because they were just treated with platinum-containing chemotherapy and taxanes, etc. So many of these patients may have hematologic adverse events. What we do in my system is that once we notice these patients are stable, 6 months out, a year onto therapy, we may push out how frequently we monitor their labs, but early on, we may even monitor them more closely than a monthly basis. Now, lastly, it's also important to note that 3A and 3A4 inhibitors and inducers can certainly interact with these agents such as olaparib. So also not just outside of our pharmacological agents, but things like grapefruit juice, Seville oranges, if you live on the West Coast, are always going to be important considerations for our patients.
Thank you, Dr. Hanna. Great overview, greatly appreciated. because it goes right into our case to update Helen. Helen started on olaparib maintenance, 300 milligrams, PO, BID, as first line maintenance, and the plan was for 2 years of treatment. She had no significant side effects other than fatigue, which, though she had the fatigue, it did not prohibit her daily activities. Her labs were normal, stable, with an ANC, hemoglobin, and platelet all within normal range. Her CMP, which included her serum creatinine and LFTs, were also within normal range. Her CA125 came down to 14. We continue to monthly labs and return to clinic every 2 months. She was on medication, which is listed here, but I kind of look at this case and say that this was a patient that I probably think, based on your data, would go beyond the 2 years that you showed and would be successful at being on a PARP inhibitor and having progression free survival for a long period of time. Dr. Hanna, any thoughts?
I totally agree with you, Dr. Morris. I think in terms of this patient, having been treated, we saw where she sits in terms of, her BRCA mutations, HRD positivity, et cetera. So she's absolutely someone that I would put on a PARP inhibitor. I think, that data from Solo One was pretty robust. Um, and it's very hard, in a specific patient like this, who potentially has a very, very, a very good opportunity to increase that progression-free survival, to justify observation in this case. Dr. Smith, what about you? Would you add anything different to this case?
Yeah, no, I think our patient population, we do see a lot of fatigue, and it's a lot to do with their prior chemotherapy, and offering them to support their hemoglobin, because anemia is the most predominant thing that we see with olaparib. Um, Even though they may not be anemic, their hemoglobin may be lower than their baseline, and so offering them multivitamins with iron, and trying to help increase their protein intake to help their energy levels as well, and giving them some exercise management will help address that fatigue. We do occasionally have to do a dose reduction due to the fatigue if it does start to interrupt their daily activities. But yeah, this was a good candidate for alaparib.
Thank you, Dr. Smith. Greatly appreciated. We're going into our second case. Tanya, a 63-year-old woman, developed right flank pain and went to the local ER. Ultrasound of the abdomen pelvis revealed anterior and posterior fibroids with a mass. MRI revealed multilobular right ovarian mass extending into the right lower quadrant of the abdomen. CT results showed retroperitoneal lymphadenopathy without pulmonary nodes. 4 months later, she received total hysterectomy and oophorectomy, total omenectomy, and radical tumor debulking. Pathology was stage 3A, high-grade serous ovarian adenocarcinoma. Genetic testing, HRD, positive, BRCA negative. Tanya starts paclitaxel, carboplatin, bevacizumab. 4 months later, CT showed no metastatic disease. In this case, this patient could be considered for a PARP inhibitor. Dr. Hanna, what are your thoughts about a PARP inhibitor in this particular case?
So absolutely, this patient not having a BRCA mutation, that HRD positivity still can deem this patient appropriate. And I think that kind of helps us segue into the Paula trial. So I think, when we talk about this specific clinical trial, this looked at our olaparib combination with bevacizumab. So instead of treating patients with just a VEGF inhibitor, so it was randomized in terms of olaparib plus bevacizumab, same dosing for olaparib versus placebo plus bevacizumab. As you can see on the left-hand side, the inclusion criteria in this clinical trial mimicked a lot of the things that we saw in Solo One. Newly diagnosed, FIGO score stages 3 and 4, and had high-grade endometrial ovarian cancer, fallopian tube, or primary peritoneal cancers. And these patients were treated in that frontline setting in terms of maintenance. They still underwent surgery had platinum-containing chemotherapy, and these patients, could have had 3 or more cycles of bevacizumab. They were stratified based on tumor, having that BRCA mutation, and also first-line treatment outcomes. We wanted to look into that. And as you can see at the bottom of the schema, is that the primary endpoint was also an investigator says PFS per RECIST. We looked at the sensitivity analysis by looking at PFS by blinded review, and also secondary endpoints are all listed there, similar to what we were trying to do also out of Solo 1. And interestingly in this trial is that, and again, this kind of goes back to that case we were just talking about, those patients who were HRD deficient, what we noticed is that they benefited whether or not, we included BRCA mutations or the BRCA mutation was excluded. So the navy line on the first 2 Kaplan-Meier curves represents the combination olaparib plus bev. The orange line represents placebo plus bev, and you can see there that there was a clear differentiation. Now, those who had a BRCA mutation, you see slightly improved numbers. You look at the median progression-free survival, 37 months in terms of olaparib plus bev versus about 18 months with bev alone or bev plus placebo. And those that the BRCA mutation was excluded or wasn't prevalent or wasn't present, that median progression-free survival was 28 months in terms of the combination therapies, Parp plus VEGF, versus 16 to 17 months or so for VEGF combinations. But clearly, though, on the right-hand side, those patients who didn't have that HRD mutation and their BRCA mutation was unknown, the data was a little bit inconsistent there in terms of Parp inhibition, adding a significant benefit on top of VEGF. So you can see that the lines are almost, transposed to one another in terms of that data. Now, safety, it's not surprising. You're giving patients 2 drugs versus giving them 1 drug. We saw slightly higher AEs in terms of patients treated with olaparib plus bevacizumab, but bevacizumab in general is generally very well tolerated across the board. Other than maybe some hypertension, maybe some proteinuria, we don't have a lot of problems with bevacizumab and tolerability. Now, in terms of this, you can see that all grade treatment-related adverse events, 99% in the combination, 96% in bev alone treated patients. Now, again, this is really interesting. And if my colleagues later want to speak to this, I would kind of be interested to hear their insights. But hypertension, the incidence of hypertension was lower in olaparib plus bev versus bev alone. So interesting to kind of see some differences there. But as you can see, anemias were prevalent when we combined the therapies. Lymphopenia, fatigue, and asthenias were slightly higher in the combination treated group. Serious AEs in both arms, about 30% of patients had a complication. Now, dose interruptions because of an AE, about 50% of patients in the combo versus about 1/4 of patients in the placebo plus bev group. Reductions and discontinuations, you can also see there at the bottom that slightly higher numbers were observed in the combination versus placebo plus bev. So some considerations there, I would say outside of everything that we've said thus far in terms of considering olaparib, I think when we talk about bevacizumab, there are going to be some added things. So again, monitoring your patients for hypertension is going to go hand in hand with everything else that you're going to be doing for olaparib. So making sure that your patient knows how to do it, that they have a blood pressure cuff, that they know how to take averages, that they weren't just running on a treadmill or had a very large glass of coffee and they're checking their blood pressure. We don't want that false elevation. Sometimes patients may have white coat syndrome when they're coming in. So making sure that we're evaluating all these things for our patient population. But also on top of that, as I mentioned, bevacizumab, we do have to add on top of our CBCs and CMPs, you should probably be checking urine proteins to make sure that your patient is not having a lot of protein wasting. These drugs are highly protein bound. We want to keep up their protein levels. So if you have a drug that leads to proteinuria or protein wasting, and then you have a drug that's highly protein bound, if you have low levels of protein, you could see increased AEs from the Parp inhibitor. So making sure that all those are clinical considerations that you have in place when you combine these therapies. And then obviously, financial toxicity is always a concern there. So educating the patients, assessing their blood pressures, urinalysis, all of that's going to be part of their treatment landscape. Now, it's always interesting to look at pharmacoeconomics, and my colleague, Dr. Smith, actually has done a lot of work in this space, so I'll be asking her opinion here in just a second, but Cost effectiveness is very, very important. Does it make sense based on the mutation that the patient has? And just what we talked about this clinical trial, if patients did were HRD proficient, that does it make sense to go olaparib bev versus doing bev alone? Because the costs are certainly there. Dr. Smith, what's your opinion there? In terms of the pharmacoeconomics of this and our patient population presentation, what would you kind of give us, the scoop here in terms of pharmacoeconomics of these regimens?
So in her scenario, I mean, she is HRD positive, so it may be appropriate to use the PARP inhibitor alone. The addition of bevacizumab has not shown to be cost effective in this scenario. So I think we need to start thinking about patient selection with her HRD status. The PARP inhibitor alone might have been a better choice.
Thanks, Dr. Smith. Dr. Morris, you want to get us back to our patient Tanya?
Oh, yes, definitely. Happy to talk about our update about Miss Tanya. Thank you, Dr. Hanna. So the patient started on olaparib, 300 milligrams POBID, and bevacizumab, 15 milligrams per kilogram for first-line maintenance. After 3 cycles, CA-125 equaled 19. She experienced some side effects. She had a hemoglobin of 6.6, shortness of breath, and required blood transfusions. Her ANC and platelets were stable. Her creatinine clearance was about 60. Her serum creatinine was about 1.1, stable with LFTs within normal range. Her blood pressure was 127 over 81 baseline, but in the ER went up to 157 over 84. You could tell she was on blood pressure medications and also medications for nausea. Due to her fatigue and low hemoglobin, the olaparib was held for 1 week. Patient would return to clinic to determine options for further treatment. So, considering the 2 options here, Dr. Smith mentioned that this patient might be a better option of just olaparib by itself versus the bevacizumab. She was on both bevacizumab and the olaparib, but due to the side effects she experienced, it was held. So now we look at the opportunity of dose reducing as a next option, reduction to 250 POBID or 200 POBID. And maybe, like Dr. Smith said, giving additional medications for anemia, like iron or vitamin B12, to help increase that hemoglobin, or maybe IV iron might be an option. Her creatinine clearance is 60, so does fall within, she does not fall within the 200 milligrams per POBID, but considering she had significant side effects, that might be an option as well. Blood pressure monitoring at home. We definitely want to make sure that she is not becoming hypertensive while she's on the bevacizumab and seeing how she does when she comes back to clinic. So, Dr. Hanna, any thoughts on this one?
No, I totally agree kind of with the recommendation, that we've made for this patient. And kind of we would follow her based on what's going on. We may, consider dose reductions, as you mentioned. If her creatinine clearance worsens, we may do, some type of intervention there. But, I think too, amidst everything that we've had, I do, agree with Dr. Smith in terms of potentially going just the oral route is a great opportunity for this patient based on her presentation. And then two, just considering everything we've been through in these past 3 years, right? And it's just the pandemic keeping people out of the health system, and they tolerate these therapies pretty well. So not much more that I think I would add there, unless Dr. Smith has anything else.
Yes, absolutely. So she has some significant anemia here with a hemoglobin of 6.6. So she absolutely needs a dose reduction. I'm not a fan of the 250 BID just because it is 2 different tablets. And, we're talking about older patients that get confused very easily. So the 200 milligrams BID and her creatinine clearance, maybe not within that window, but considering the significant anemia of, she absolutely needs a dose reduction. We know that bevacizumab and proteinuria, we don't have her urine creatinine protein ratio or urine protein status in this information, but it does alter renal function. And so knowing that the PARP inhibitors do have renal clearance and it can be inhibited, I think that going to the lower dose for her would be most appropriate. and really following up on holding the BEV until we do find out what's going on with her urine function.
Wonderful, Dr. Smith. Thank you. I agree. I think an unmet need sometimes in these PARP inhibitors is creatinine clearance, and it should be monitored on a continuum. And holding the bevacizumab and reevaluating the olaparib, it sounds like a great choice. So thank you. So our third case, Miss Maria, a 76-year-old woman, presented to the ER with shortness of breath and abdominal pain. Biopsy showed high-grade serous carcinoma. She started on neoadjuvant paclitaxel carboplatin times 5 cycles. Her CA-125 before she started treatment was 27,832. We see high CA-125s. This is one of the highest I've seen, and I'm sure my colleagues have seen higher. 4 months later, she had a total hysterectomy, oophorectomy, omenectomy, debulking, followed by 3 more cycles of paclitaxel carboplatin. Her CA-125 went to 216. Genetic testing was LOH was equal to 16. Germline testing was negative. Her platelets were at 240, and her weight was at 78 kilograms. Maria elects to pursue treatment with a PARP inhibitor. I guess now we're looking at a different option for this particular patient population. I'd now like to hand it over to Dr. Judith Smith, a professor and director of the Women's Health Integrative Medicine Research Program in the Division of Gynecologic Oncology in the UT Health McGovern Medical School. Dr. Smith, can you take us through some of the data and important points to keep in mind for a case like Maria?
And Maria is a common case where we are seeing that she doesn't have HRD status or a germline mutation. However, Neraparib is one of the PARP inhibitors through phase 3 studies has shown to have efficacy in this patient population. So as we think about creating a management plan for this patient, she will need to coordinate her care as far as monitoring for adverse events. Typically, when we're starting a patient on a PARP inhibitor, it's weekly labs. And then once they're stabilized, don't need dose reductions, then moving to the monthly labs and thereafter, like Dr. Hanna alluded to. But those, every time a dose adjustment is needed, it kind of resets that clock for the laboratory monitoring. So once we have them on a stable dose, we can push out the lab time period. With these oral agents, I think it's really important to be counseling the patients and setting expectations, because the concept of just coming off of IV chemotherapy and the toxicities, they think oral chemotherapy will be less toxic. And the PARP inhibitors do have their share of side effects. The nausea is significant initially until they get used to it. With Neraparib, we do have the benefit that you can just take it once a day, so it can be taken at bedtime and offset some of that experiencing of the nausea. And then the importance for using nutritional supplements to help support their hemoglobin, protein, as we talked about before, to help maintain their nutritional status, and then just overall making sure that they're monitoring different side effects that can creep up. So let's go through the PRIMA study data, which looked at Neraparib in newly diagnosed ovarian cancer patients in that first-line maintenance setting, similar to the SOLO-1 study that Dr. Hanna presented. So you look at these Kaplan-Meier curves, you can see the primary endpoint was progression-free benefit. In the separated out on the left-hand side is those patients that specifically had an HDR mutation. And then in the right-hand side, the overall population. You can see, regardless of this HRD status or BRCA mutation, we did see a good response in both patient population. And specifically in the overall population, this is helpful to know those patients that may not have those mutations may still have a benefit from the PARP inhibitors, particularly Neraparib. So when we look at I mentioned that in the PRIMA study, and the first-line maintenance study, they started to try to individualize the starting dose for Neraparib. The initial FDA-approved dose was 300 milligrams, or is 300 milligrams once daily. However, on those in the initial studies at 300 milligrams and in clinical practice, we're seeing significant amount of thrombocytopenia. When they did some secondary analysis, there was a suggestion that patients' initial platelet counts or a lower body weight were more susceptible to thrombocytopenia. So in this PRIMA study, they evaluated individualizing the dose for patients who had a platelet count less than 150,000 or body weight less than 77 kilograms, started at the 200 milligram dose. And they saw that they had better tolerability in this study compared to the higher 300 milligram dose. And so that was what you see in the current FDA approval for first line maintenance, is at the 200 milligram once daily if they have a platelet count less than 150,000 at baseline or body weight less than 77 kilograms. But when we look at some practical considerations for Neraparib, as I mentioned, there is the 2 dose levels. And then looking at the management of adverse effects, nausea is helpful to offset by taking it at bedtime and making sure that they have antiemetics at home that they can take. If they start to experience nausea, we typically will recommend for them to take the following day to take a nausea medication about 1 hour before taking the Neraparib to help offset that. Also, increasing their protein intake can offset the nausea, increasing hydration, which helps also with their renal function. And then continuing to monitor them, as I mentioned before, weekly initially, and then spreading that out as long as dose reductions aren't needed over the first month. We also do monitor for hypertension and cardiovascular side effects, especially in our obese population. So when we look at some of the potential risk factors, this is something our group here really has dug into a little bit deeper, is that while the package insert and labeling really focused in on body weight and platelet count, we know that the Parp inhibitors as a class are inhibited of the MATE1-2 renal transporters, which you probably haven't thought about or maybe haven't thought about since pharmacology. But the MATE1-2 transporters decrease creatinine clearance because this is the pathway for creatinine. And it's the Parp inhibitors are also substrates of this, so they can inhibit their own clearance. And we have seen that over time, patients that have decreased renal function are more susceptible to Parp inhibitor toxicity with Neraparib or Olaparib. Olaparib does have dosing recommendations based on renal function. And Neraparib, I know that's something that's a work in progress. So in consideration of not only the body weight, because we had patients all with body weight greater than 80 kilograms, some almost greater than 100 kilograms, and platelet counts well over 200,000 that still suffered significant thrombocytopenia to less than 10,000. And it was more associated with their renal function rather than any of those baseline parameters. So while that can be a guidance for you when you're initiating therapy, you do also need to take their renal function into consideration, as well as we mentioned their protein status, because these drugs have over 80% plasma protein binding. Alterations in that, especially coming off of chemotherapy for 6 cycles of Taxol carbo, which is our typical baseline, they might need some support in getting their protein levels back up.
Thank you, Dr. Smith. Great review of those risk factors for pharmacists to learn from your institution. So thank you. Update on Maria. Side effects include fatigue, nausea, constipation, diarrhea, rash, reaction, thrombocytopenia, abnormal thyroid labs. Due to fatigue and low platelets, Neraparib dose was held and then changed to 200 milligrams PO daily. Platelets did go as low as 84, and her weight is 72 kilograms. Maria continues on 200 milligrams PO daily without issue. Her active medications are listed, and basically with her going to a lower dose, I guess the question always poses, should she have gone to a 200 milligram PO daily since she was so close to the parameters that Dr. Smith mentioned? or putting her on the higher dose and then dose reducing her, making it better for Maria to tolerate the drug is the option that came about with this case. Dr. Smith, any thoughts on this?
So this is a really good opportunity to pharmacists to advocate for the patients. In the maintenance, first line maintenance setting, we typically, knowing the significant toxicity with these starting at the 200 milligram dose, that patients may tolerate better. If need be, we can increase the dose if we suspect that they're not having a stabilized C125. But starting at the 200 milligram dose may be tolerated better, and the patient may be more compliant long term on that as well. The downside of starting at the higher dose and dose reducing is also you get into scenarios where you have excess drugs and pills accumulating that the patient may not need. So we typically start lowering and increase as needed.
Dr. Hanna, any thoughts?
No, we would have a similar approach too. And I would probably monitor this patient a little bit more closely, considering, how low she got. She is a smaller, somewhat on the smaller end kind of patient. Um, you know, Probably looking into her proteins, as Dr. Smith had mentioned. I think, I kind of learned that from Dr. Smith, that, the impact there. And then I think, for us as pharmacists, if you're not specializing in this area, the PI will dictate what you do, right? And you take that and you build that in your EMRs, not taking into consideration some of the other very important clinical factors. And that 18% plus protein binding is going to be very important. So certainly agree with the 200 starting daily dose.
Wonderful. Yeah, I think that's a consensus for this patient. So thank you. We know that a lot of our experience with PARP inhibitors usually comes from the setting of platinum sensitive, high grade relapse ovarian cancers. Dr. Smith, can you walk us through some of that data as well?
So the PARP inhibitors back in 2014, when they first, starting with olaparib and then the following with rucaparib and then neraparib, really started in those patients that had already had stabilized disease either on a platinum-based therapy. Typically, platinum sensitive is what we really focused on when these agents were first introduced to market. And whether or not we could stabilize them with the PARP inhibitors. So we had 3 studies. This Solo 2 study, or study 19, the NOVA study, and then the Ariel study that looked at rucaparib. Okay, so when we look at these pivotal studies that were involved in the approval for the PARP inhibitors and with patients with recurrent ovarian cancer, study 19 and Solo 2 were the first 2 studies, and you can see the difference in progression-free survival in those patient populations compared to placebo. The study 19 was not as significant as Solo 2, where we saw 19 months versus 5 months. And then you look across to the NOVA study, again, in those patients with that germline mutations, you see a very significant jump with 21 months versus 5 months with placebo. And then in the Ariel study, again, those patients with the germline mutation, we saw a significant difference with those patients with a germline mutation. Right, bring it back to the other NOVA study, again, looking at those patients without that mutation, as I mentioned in the PRIMA study, even in those with neraparib, those patients without a germline mutation still had, over a 6-month advantage versus placebo with the absence of having no mutation. So these studies were all done in patients who had not had prior PARP exposure. So they're, PARP inhibitor naive because they were just being introduced to the market. Now they have moved into our first line maintenance setting. And so we're still learning now to see how the response rates will be in the patients who've already had PARP exposure. So before we get there, looking at the Ariel 4 study that looked at rucaparib versus the standard of care in patients with a germline mutation versus a non-germline mutation, Again, patients were randomized 2 to 1 to either Neraparib 600 milligrams twice daily, or if they were platinum resistant, a taxane and paclitaxel based regimen, or if platinum sensitive, a doublet chemotherapy such as Doxil and carboplatinum or something similar. And the study's primary endpoint was again looking at progression-free survival based on investigator assessment. In this Kaplan-Meier curve, you can see the dark navy blue line represents the Neraparib patients versus the chemotherapy. And they did have a statistically significant improvement with Neraparib compared to standard chemotherapy in these patients that received the Neraparib in this second line setting. So when we think about dosing Neraparib, it's another BID drug, so it's 600 milligrams twice daily, and it has multiple strength tablets of the 200 and 300 milligram tablets that can be adjusted to meet the dose. We typically dose reduce to either 500, 400, or 300 milligrams BID. One of the really important things as a pharmacist to keep in mind as you're considering which PARP inhibitor to use is looking at that patient's medication profile, their comorbidities and other medications they may be on, and look at the potential for drug-drug interactions. So one of the things with Neraparib is that it's not only a substrate of that cytochrome P450 system, but it's also an inhibitor of 1A2, 3A4, as well as the 2D6 pathways. So multiple pathways that it's inhibiting. One of the ones that we don't think about as much because it's not a lot of drugs that are substrates to 1A2, but one of the common things that we find in our food, like caffeine, and these women do drink a lot of caffeine to counteract the fatigue associated with the PARP inhibitor, that it does inhibit the breakdown and clearance of caffeine, so they can have risk of hypertension and arrhythmias. Your patients that may have existing hypertension, this might not be the right drug, PARP inhibitor for them, and might want to consider an alternative. As I mentioned before, the initial studies were done in patients who were PARP naive. And now we're looking at the phase 3 Oriole study that looked at re-challenging these patients with a PARP inhibitor in the second line setting. And this study randomized patients to olaparib versus placebo to see whether or not, and patients had all had at least one prior PARP inhibitor, and differentiating similar to you've seen in a lot of the gynecologic oncology studies, looking at the duration of time since that prior exposure, stratifying by either greater than 18 months versus greater than a year. And then also in the non-BRCA mutated patients, looking at greater than 6 months or versus 12 months. When we look at the patients that received the re-challenge with olaparib, again, the PARP arm represented in the navy blue and placebo in orange. On the left-hand side of the patients that did not have a BRCA mutation, and the right-hand side of the patients with a BRCA mutation. In both of these Kaplan-Meier curves, you can see that olaparib did serve a benefit and heavily pretreated ovarian cancer patients and re-challenging them with maintenance PARP inhibitor in response to, after having a response to platinum-based chemotherapy. So back in 2016, 2015, we had coined the term switch maintenance, and that would be how we would classify what we're doing here and maintaining them, then getting them, as Dr. Hanna mentioned earlier, out of coming to the clinic, taking home therapy, and maintaining a good response and progression-free survival.
Thank you, Dr. Smith, for that overview of the Oriole trial. It's very impressive to know that we can re-challenge these patients after getting chemotherapy. So it's good to have that data available to the pharmacists. So thank you. Listed below are trials that are investigating PARP inhibitors in combination with immunotherapy. Pembrolizumab, olaparib, the DUO trial, durvalumab, chemotherapy, bevacizumab. As you can see, the PARP inhibitors are being utilized in multiple regimens in investigating the options of using immunotherapy, VEGF, and PARP inhibitors. So as both Dr. Hanna and Dr. Smith have discussed and have given us a great overview for pharmacists to really dive into PARP inhibitors, the common AEs of PARP inhibitors, hematologic, anemias, thrombocytopenia, neutropenia, seems to be the area that we're looking at to really help these patients stay compliant and maintain themselves while they're on PARP inhibitors. Non-hematologic, nausea, vomiting, anesthesia, fatigue, diarrhea, constipation. I would add the renal function as well, creatinine, serum creatinine, albumin, things like that, can also help keep these patients at the doses that they need to stay compliant. Though we talked a bit about it, rare is AML, MDS, and pneumonitis. As the data was presented, it showed that this can happen, but it is a low percentage, but it is information that you can talk to your patients about to make sure they're aware. There's also a download practice aid that's available for you on this as well. So I bring my colleagues into this one as far as hematologic toxicities or common AEs. By interrupting a PARP inhibitor, monitor blood counts weekly, hematologic profile recovery, restarting a drug at a reduced dose, hematological profiles that not recovered in a grade 1 after 4 weeks. Dr. Hanna, Dr. Smith, what is your take on this basic information when it comes to the hematological toxicities of PARP inhibitors?
I think for us, kind of like we had mentioned, for the heme toxicities, it's very important to monitor these patients at least on a monthly basis. You may need to do it even more frequently early on into their treatment if they do have pre-existing low counts. And if my patient gives me lower platelets, I may monitor that patient a little bit more closely, at least in the first couple of cycles. We've implemented protocols when you're far enough out and you have been stable. We'll do labs every 3 months, every 2 to 3 months, and they'll actually see a provider every 6 months with a mid-level checking in virtually for these patients. Has helped alleviate some of the challenges and follow-ups. Dr. Smith, would you guys do anything different for this patient population?
Well, my experience with these patients coming out off of taxane and carbo is that hematologic toxicity in the first month can be significant, and until we find the right dose that they need to be on, a lot of them have renal insufficiency from the prior chemotherapy as well that may recover or may not. So we do recommend weekly monitoring until we have them on a stabilized dose, and then we'll spread those appointments out. Based on what else is going on in their clinical picture. Being that for ovarian cancer, they need 3-month surveillance visits anyways. We're seeing them every 3 months at minimum. And then maybe moving out, after they get beyond that 2-year point, which they would be coming off of PARP therapy anyways.
Thank you. Now listed for non-hematological, both of you, Dr. Hanna and Dr. Smith, mentioned antiemetics, lifestyle modifications, behavioral modifications, fatigue levels, monitoring these patients if they're having too much fatigue and what the options might be, physical activity, good nutrition, hydration, sleep hygiene, and also considering dose interruptions or dose reductions for severe fatigue.
Yeah, absolutely. I think those are all good points to make sure that you're educating those patients up front and making sure that they understand they are going to have some side effects that need to be managed, and they need to let us know when it is not improving so that we can adjust doses appropriately.
Pharmacokinetic profile for PARP inhibitors listed here for olaparib, neraparib, and rucaparib. You can see the pharmacokinetics that can help pharmacists in determining the appropriate dose for their patients with ovarian cancer. Dr. Smith had mentioned previously about the protein binding. Dr. Hanna had also mentioned it as well. So, Dr. Smith, do you want to elaborate on anything pertaining to this slide?
Just the other thing, I just echo, we talked about the drug-drug interactions and making sure we not only recognize that there's substrates of these, the CYP3A4 pathway, but Neraparib is actually an inhibitor of the 2D6 and 1A2 and 3A4 pathway. And that really comes into important when you have patients on multiple other medications.
As a summary, practical points, who should get a PARP inhibitor, consider patients newly diagnosed with ovarian cancer, BRCA and HRD. Also, Dr. Hanna mentioned HPR, balanced discussion, risk benefit with the providers. And in recurrent ovarian cancer, PARP inhibitor naive patients, irrespective of BRCA or HRD status. Genetic testing, we know this is normally done now more upfront, tumor testing, etc. And then managing toxicities. We've talked about patient counseling and education, monitoring, blood tests, hypertension, AML, MDS, possible dose modifications, and supportive measures. Pharmacy practice points. As many of us pharmacists, we are always talking about manufacturer patient assistant programs, free drug programs, copay assistance, etc. Navigating and finding out what patients are eligible and submitting these forms with the hope of them getting coverage or free drug. Patient education, setting the experience for these patients, on making them understand the drug-drug interactions so that they know that if they're on medication that could interact with the PARP inhibitor, that they might have to have dose reductions in order to stay on the dose that's best for them. Giving them prescriptions for antiemetics. We've seen some of our case patients that were on antiemetics, and as Dr. Smith and Hannah both mentioned, giving it at bedtime helps alleviate some of that nausea during the day. And then supportive care, nutrition, protein shakes, hydration, etc. Those things are what patients can have and kind of maintain while they're at home. I'd like to do a very special thanks to my colleagues, Dr. Hannah and Dr. Smith, for joining me in this discussion. Once again, you can visit us at peerreview.com/ovarian2022 to complete and submit your post-test and evaluation, apply for credit, and download the slides and practice aids. Thank you for joining us.